All right. So, hi everyone. My name is Laura Gadenik. I'm the program coordinator for TICN. Um, we started TICN, or Kristen co-founded TICN back in 2014. Um, and it's shifted a lot since then. Ever since COVID, it's been kind of smaller. We were doing monthly presentations, and we'll probably get back to that now that the summer is finalizing. But yeah, mostly we do monthly presentations. I'll send out an occasional newsletter here and there. And yeah, I'm also a therapist at Healing Pathways, and I do neurofeedback as well. So um, that is me. And let me go ahead and introduce Dan. So Dan is a research assistant professor at the Department of Neurology at the University of Utah. He received his Ph.D. in medicinal chemistry and pharmaceutics from the University of Jerusalem, where he gained extensive experience in drug design and synthesis. He designed and synthesized a novel potential anticonvulsant and migraine preventive compound, SPD. And this new compound, which is currently patented, showed great promise in preclinical models for epilepsy, neuropathic pain, and migraines. In the last several years, he studied the modulation of migraine by sex, stress, and affect, and has expanded his interest to address musculoskeletal pain and fatigue. And yeah, his long-term goal is to apply his skill set broadly, pharmacology, physiology, and behavior, to understanding and treating migraine pain. This interest has also led him to pursue training in hypnotherapy, neuro-linguistic programming, biofeedback, autogenic training, unified protocol, and emotional awareness and expression therapy. And he's also currently training to become a licensed clinical mental health counselor. So lots of training, very impressive. And yeah, I will pass it on to you, Dan, if you want to share anything else about yourself and get started.
Yeah, absolutely. Okay. Well, thank you very much, Laura, for this introduction. I hope that everybody can hear me okay. And if not, then just let me know and I'll maybe increase the volume. So it's a pleasure to be here in the TICN. I still remember, many years ago when TICN started and with Kristen Warnick and when we started to have those presentations. And so it's always a pleasure to come back. What I would like to do today is to talk about migraine and trauma, but even though I'm going to focus on migraine, I'm also going to provide a lot of information about pain in general, because all the information that I'm going to provide in this presentation is not just for migraine. It can be expanded for other chronic pain disorders. And let me give, and again, Laura gave some background about me, but let me just explain a little bit more that for the past 25 years, I've been a basic scientist, did all the work, scientific work in the lab, mice, rats, nerve cells, all that. But the research led me to areas that I wasn't prepared for. And with the years and trying to understand a little bit better what chronic pain is from the person perspective, what migraine is from the person perspective, it was very clear to me that the whole notion of trauma is not just important, it's critically important if we really want to help people better their condition and not just live with migraine, but really provide therapies that could have a profound effect on people with migraine. We have to address the trauma perspective. And so what I'm going to be talking about in this presentation today is, before we delve into trauma or migraine, first I'd like to talk about pain in general, because I think that there's a lot of misconceptions, a lot of ideas about pain that might deserve a different outlook. Then, as we're going to talk about pain, the definition of pain, pain signaling, what happens in chronic pain, we're going to move to migraine and understand that migraine is not just a headache. There's a big difference between the two. And so what is migraine? How do we identify migraine? And what is the correlation between migraine, stress, emotional disorders, trauma, and so forth and so on? These are pretty prevalent for people who are living with migraine. And we're also going to talk about the behavioral interventions that are currently recommended for chronic pain in general and migraine in particular. And we're going to talk about what might be some of the issues of those behavioral approaches. And then I'm going to be talking about my current research that I'm evaluating a novel intervention that is trauma related, and it's called EAET, or Emotional Awareness and Expression Therapy. I'm going to talk about what is that, how is that different than current approaches that are used for chronic pain and migraine, and some of the responses that we got from participants as we've done quite several groups with EAET. And I know that I can talk about the AT for a long time, but that won't give participants the ability to understand what's the treatment. So I'm going to have two videos to just show how does the process look like a little bit when we do that in group. And then we're going to summarize. So I want to start by saying that we see a lot on the news and the internet. We see a lot of information about chronic pain, such as the war on chronic pain, a demon in the brain, which is pain, fighting pain in the US military. The medications for pain, we call them painkillers. So it's like we all have this notion that pain is this horrible person, this horrible thing. We need to fight it, to eradicate it, to kill it, to make sure it's gone. And that makes sense because pain is, especially when it's debilitating, when people experience chronic pain, it's definitely not a pleasant experience. It's a very debilitating, it's a traumatic experience. So naturally, we want to eradicate that. But in this presentation, I want to take a step back and I want to look at pain from a different lens and from a different perspective and ask ourselves, when we think about pain, what is pain? Why do we have pain? So the definition, one of the definitions, at least from the International Association for the Study of Pain, is that pain is an unpleasant sensory and emotional experience that is associated with actual or potential tissue damage, or that can be described in such damage and terms. We need to understand several things about this. First, as I highlighted here in the slide, pain can be a sensory and an emotional. Go ahead, sorry, Laura, you wanted to?
I'm just gonna say we don't see your slides yet.
Oh, I'm sorry. That is okay. Oh, I'm sorry. Again, I didn't share my screen. Of course, you can see my slides. Sorry about that.
Worries.
Okay, so I'm sorry. So I was talking and I didn't share my slides. So this is the outline again, as I'm going to be presenting it. We're going to start with pain, migraine, behavioral intervention, the issues, and emotional awareness and expression therapy. And I started talking about the war on chronic pain, a demon in the brain, and so forth and so on. And this is the current understanding or how do we view pain that makes sense. However, again, when we think about what is pain, pain is an unpleasant sensory and emotional experience, as I mentioned. It has two branches. One, it is a physiological sensory experience, as we're going to see in the next slide, and it's also an emotional experience. When we look at pain, we need to think about why is it that we have pain? Why did evolution create this horrible thing that is called pain? But when we look at it, pain is a phenomena that created by evolution, and the whole reason is to protect us from any potential tissue damage or real tissue damage. So if I take my hand and put it on a hot stove, I'm going to experience pain because the system is telling me, hey, you need to be careful. You need to withdraw your hand because otherwise you're going to have a real serious danger or damage. And the idea is that the reason that it's so unpleasant is to serve a purpose, because the unpleasant sensations associated with pain are designed so that we can pay attention to what is happening. And so I know that a lot of times when I talk to people that suffering from chronic pain, I tell them, there are some people that have a genetic mutation that they don't experience pain at all. And the immediate response I'm getting is, oh, I want that. Oh, they're so lucky. But actually, those people with the genetic mutation, they don't survive for long because they don't have this system that is supposed to warn them of danger or damage. So if God forbid something serious is happening, they won't know. And so, as I mentioned, every pain, in my opinion, has both a physical and emotional component in different proportions. And it's important to address both because, yes, we do have the whole neural sensory component, but there's also an affective component, which is not as easy to measure as the physical component. We also need to understand that pain exists as a response to threat. So let's look a little bit more at what happens physiologically when we think about pain. So as we look at the schematics, we have a hand here on the left, and we have these special nerve cells. Those are called nociceptors, shown here in black. Those are special nerve cells that when they are activated, because this threshold for activation has been breached, they send a specific message through electrical impulses, because that's how the nervous system functions. The impulses are going all the way to the spinal cord, from the spinal cord to the brain in the first area, which is the thalamus, and from the thalamus to other areas in the brain. And in those other areas in the brain, in a fraction of a second, a story is being created. And the story is, what is this sensation? Have I experienced that before? What does that sensation mean? Am I in danger? And that takes a fraction of a second when many different brain areas are activated. And the fact is that eventually, if the brain decides that the person is in danger, it will produce a pain response. If it doesn't think or doesn't get to the conclusion that there is danger, it will not produce a pain response regardless of the intensity of the stimulus. And that is the main message I want to convey in here, because pain is a result if the brain determines that someone is in danger. And that's the only reason that it will produce pain signals. How do we know about that? Because, for example, there are some cases that were documented in, I think it was First World War, I don't remember if it was First or Second World War, that soldiers that came back from the battlefield, some of them had horrendous injuries, and they did not report too much of a pain level, versus others that it didn't seem as if they had too much of a severe injuries, but they reported debilitating pain. So that just to say that a lot of people, when they think that pain is because of the damage or the injury, but actually pain is much more complicated than that. It's not necessarily correlated with the specific injuries that we have. There's a lot of meaning for the pain. And I want to show my next slide, which might be a little aversive to someone. So I just kind of want to make sure if people don't want to watch, then just be warned. This is actually something that happened to about a builder. I think he was about 29 years old. And he had an accident in this site that he was working. He jumped out of a place, and this nail, which was a 15 centimeter nail, just pierced its boot. And he was in so much pain that they needed to completely sedate him. He just was in complete agony. After he was sedated, when they took the boot off, they found that the nail pierced in between his toes. It didn't even touch him. So there wasn't an actual damage to the tissue, but the person experienced the pain as if it was real and was debilitating. And that needs to tell us something. It needs to tell us that the brain is not just a passive conduit that just transmits information. The brain can create pain sensations if it seems, or if the idea that the story that has been created, indicates that the person is in danger. And we also want to know a little bit some more facts about pain, because pain is also dependent on context, meaning finger injury, which might be identical between two people, can produce different pain responses. For example, someone who is a violinist who needs this finger maybe as a career might experience finger injury much more than like a dancer or someone who constantly get injuries in their fingers, or doesn't attribute too much meaning to a finger injury. To give another example, let's just say, and of course I'll never do that, but let's just give an example. Let's say I meet one of you on the street and I bump into you and I said, "Oh, I'm sorry, please forgive me, I didn't mean that." And let's give another example, that I meet you on the street, I bump into you and I say, "Serves you right. You deserve that, serves you right." Most probably the second incident, when I said "serves you right," kind of like increased the danger level, you probably would experience the pain in the second scenario much worse than the first scenario, because there's added danger component to it. We also know about the nocebo effect, that pain can be amplified if we're preceding that with anticipation. So for example, if I hook someone to electrodes and I'm going to say, "Okay, I'm going to deliver some current. It's really going to be painful, but just, bear with me." And I'm going to deliver a certain current, versus another person that I'm going to connect him to the same machine. I'm going to say, "Oh, don't worry about it. It's going to be nothing. You're barely going to feel anything." The anticipation of the pain response is going to make the pain much more severe, versus if there isn't an anticipation, just to indicate again how much the brain can function as an amplifying system for danger signals. We also know that we have virtual body, phantom pain. Sometimes people experience pain even without the specific body part involved. We know about amputees that even though they don't have a specific organ, they still feel pain in that organ. Tissue damage is not enough to explain the different levels of pain experience, because that just indicates that the brain can amplify or create pain, not just a passive conduit of information that comes from the periphery. And we also know that pain is experienced differently depending on a person's age, gender, culture. If I believe that I'm invincible, or I'm this tough guy and I shouldn't complain about pain, I'm probably going to diminish my reports of pain, and so forth and so on. Now, what is the problem when we experience chronic pain? Because all of that might be acute pain. But in chronic pain, something else happens. In chronic pain, we constantly get signals that goes into the brain in the form of a danger signal. Now, the longer the signal occurs, the more the pain threshold is reduced, meaning that the more the signal comes to the brain, the more the brain becomes more sensitive to that danger signal. It's like there are some changes that are going to happen in the brain and the central nervous system, that every input now is going to be much heightened. And with that case, the brain no longer accurately represents the danger that actually occurs. When this increased sensitivity, then all sorts of stimuli that may not be painful all of a sudden are becoming painful. These are phenomena called hyperalgesia or allodynia. And it's like the brain needs to adjust to a flood of information, and it becomes much more sensitive. So if you want to kind of use an analogy, it's like the brain becomes this symphony. Then instead of playing all sorts of tunes, now it only plays the pain tune repetitively. And it's like with this constant flooding of pain signals to the brain, it's like the brain is hijacked by this information about danger and danger and danger. With that in mind, everything that's going to increase the brain's sense of danger is going to amplify pain. That indicates that stress can amplify pain. Negative thoughts can amplify pain. A lot of things that we might consider as dangerous, because the brain is so sensitive right now, is going to amplify a pain signal, and that's something that occurs with chronic pain. Now let's take all this information about chronic pain, and now let's talk a little bit about migraine. Now, we hear a lot in the common jargon, we hear a lot of people say, oh, he gives me migraine, or she gives me migraine, or my kids are all over the place, they're giving me a headache. People a lot of times use the word migraine and headache interchangeably, but what I want you to get from this presentation is that not every headache is actually a migraine. There's a big difference between the two. So how do we know? So there's a very relatively simple tool that you can use to identify whether someone has a migraine or whether it's just a headache, not to minimize it, but it's not a migraine. So you can ask 3 questions. Number 1, are you nauseated or sick to your stomach when you have a headache? Number 2, has a headache limited your activity for a day or more in the last 3 months? And number 3, does light bother you when you have a headache? Now, if the person answers yes to all 3 of those questions, it's more than 92% likely that the person has a migraine. If they answered yes to 2 out of the 3, it's above 80% probability that they have a migraine. So this is just kind of, it's not a scientific, but it's relatively easy to use tool to kind of get the idea if it's a migraine or just a headache. But actually, according to the International Classification of Headache Disorder 3, the ICHD-3, there is a very specific classification. We're probably not going to go through everything, but what I do want you to get from it is that, first of all, migraine is considered a chronic episodic disorder, and it's not just the headaches, it's also associated with other symptoms. Migraine is very prevalent. It is assumed to affect 15 to 18, and some reports even say 20% of the population. Women are 3 times more prone to get migraine than men, especially after puberty and before menopause. And in order for someone to have a migraine, they need to have at least 5 attacks in a month, and each attack need to be between 4 to 72 hours. This is not a typo. Some migraines last for several days. Headache need to have either unilateral location, meaning you always have it in half of the head, either the left side or the right side, and it can move. Quality is pulsating. The intensity can be moderate or severe, and it usually is aggravated or caused by physical activity. People with migraine cannot perform physical activity a lot of times when they have migraine. But beside that, it also needs to accompany other conditions such as nausea, vomiting, or both, and a lot of other sensitivities, such as light sensitivity, which is photophobia, sound sensitivity, phonophobia, or smell sensitivity, like osmophobia. And when we think about the person with migraine, it's like we imagine like maybe a receiver or like maybe a radio that you took the volume and crank it all the way up. These are people with migraines. Like everything is very, very sensitive. They're sensitive to light, they're sensitive to sound, they're very emotional. They need to withdraw from any kind of stimuli because they just can't tolerate that. It's painful for them. So typically, you're going to see someone with migraine with sunglasses, even though it's 10 p.m. in the evening. They're going to maybe cover themselves with a blanket in a completely dark room, no sound, no nothing. That's how they have to get over the migraine. And a lot of people don't understand, say, well, it's night. This is ridiculous. Why are you putting sunglasses? Every little light really bothers them. What causes migraine? There's all sorts of theories. The main theory about migraine, I'm not going to get too much into detail, that there is an event that happens, and that event is called CSD. Oops, sorry. Okay. That event is called CSD, and that's a wave that travels the brain, a slow wave that travels the brain, kind of activates the nerve cells and other associated cells in the brain, and it activates the meningeal or the brain nociceptors. Remember, we talked about the nociceptors before. So migraine, in order for us to have a pain, they have to have nociceptors. Just the nociceptors of migraine are located in the area of the head, the meningeal. The information goes similarly to other forms of pain to the brainstem, and from there to the thalamus and to the brain where the pain is being perceived. I'm sorry, I want to correct it. In migraine, the information goes to the brainstem. In other forms of pain, it goes to the spinal cord and to the thalamus, and there to the brain. That's where pain is perceived. There's all sorts of triggers for migraine. People report the diet can trigger their migraine. When they're hungry, it can trigger the migraine. All sorts of food or food additives triggers their migraine, like meat or certain kind of cheeses because of tyramine. If they withdraw from caffeine, that could trigger their migraine. Hormonal, we mentioned that women are 3 times more prone to migraine than men, especially after puberty, before menopause, because estrogens have been linked with migraine. And in times of menstruation or menopause or pregnancy, there is a big changes in migraine. Either migraine go up or migraine go down. I know that I talked to someone couple of, I think it was 2 years ago, and she said, I wish I could be pregnant for the rest of my life because I didn't have a migraine during those times. Environmental also can cause migraines. All sorts of visual stimuli, like flickering lights, can cause migraine. Odors, like very distinct smells, can cause migraine. Changes in air pressure can cause migraine. And especially stress, trauma, exertion, anxiety, all of those can cause or trigger migraine. However, it's important to know that some physical factors that are triggering migraine can be relatively easy to identify, but especially emotional triggers are much more tricky to identify in terms of learning to avoid them so the person does not have a migraine. So with all of that and everything that we know about pain and migraine, what is actually the problem? What are the problems of people living with migraine? So first of all, migraine is a debilitating disorder. It's the associated symptoms, the headaches are debilitating, and a lot of people call it traumatizing. Migraine affects a large percentage of the population. 15 to 20% is a lot. I always do this exercise. I go into a room and I do a lecture and I ask, okay, who in here either has a migraine or knows of someone that has migraines? Or I didn't have even a single time that the majority of people in the room raise their hand, because it's very, very prevalent. Migraine is associated with unanticipated headaches. The people that experience migraine, they don't know when the next headache is going to come. They don't know what associated symptoms are going to be and how severe it's going to be for them. And that, when you have this not knowing what's going to be next, people are going to be anxious. They're going to be depressed. You know, what are we going to do? How can we live like this? They feel helplessness. They feel hopeless. Many people with migraine are not responding for current pharmacotherapy. They don't respond to medication. They come back to the doctor over and over and over, and they change this medication and this dose, and nothing helps them. Many people with migraine can't work, as I mentioned. Some migraines are from 4 to 72 hours. I see people that they have maybe 20 migraines a month. And that doesn't allow them to do much in life. They constantly are in some sort of a migraine state. So a lot of them are not working. They're on disability. They can't see friends. They can't see people. They don't have many people around them. So they feel isolated. Many people with migraine miss a lot of social events, especially people that have children or family members, and they simply can't participate. I mean, I hear a lot of mothers that I work with, and they feel so guilty. My kid is graduating, my daughter is graduating, and I can't attend. I have a migraine. A lot of times also, people with migraine are very stigmatized, and migraine in general is a very stigmatized disease. And migraine sufferers a lot of times feel that no one understands them, which does increase their sense of loneliness. Because if you look at someone with a migraine, even if they have an attack which they can manage and maybe not put sunglasses, they look, completely normal like you and me. So a lot of people are telling them, well, what do you mean that you have a migraine? Okay, you look fine to me. So I don't know, can you take a glass of water, maybe Tylenol, take a deep breath and kind of get on with that? But the fact is that they can't. They may look normal, but they're very much suffering, which contributes to the stigma of this disorder. People with migraine are a lot of times stigmatized that they're trying to escape things, or they don't want to do some things, or they're lazy, or they're crazy, and all sorts of things. And this is really, really debilitating for them. So besides all of that, it's not just the people with migraine that are being influenced, it's their families, and it's also society in large, because there's a lot of economical costs that go to compensate for people that are experiencing migraine. There is a very important connection between migraine and other conditions such as general anxiety, depression, PTSD. Those two go pretty much hand in hand, and it seems that the relationship is bidirectional. Now, this can make sense when someone has migraines and it's unanticipated. I mean, they can't anticipate when the next migraine is going to be. Then it makes sense that they're going to be anxious and afraid of what's going to happen next. However, also, if they already are anxious and depressed and migraine come, they might amplify the migraine even more. So it's like there's this cycle that one perpetuates the other by having both a migraine and anxiety disorder. It's also shown that major depressive disorder is 2 to 3 times higher in people with migraine, 10 times high likelihood for people living with migraine to have anxiety disorder, panic attack, and so forth and so on. And that is a big problem, because when you have a migraine and a psychiatric disorder that is comorbid to migraine, that is really associated with a much poorer health-related outcome. People have much reduced quality of life. If I'm so stressed about my migraine, I might, overtake medication when I'm not supposed to. When I take medication, when I overuse medication, that can perpetuate the problem even more, because we have what we call medication overuse headaches. People that have psychiatric disorder with migraine have an increased disability. Some have suicidal ideation or suicidal behavior. So the problem is very severe. When we look at some of the forms of stress that can exacerbate migraine, people report that childhood adversity, having physical, emotionally, or sexually abused. People that have issues in their workplace report that this is a huge stressor for them, and when they're being bullied or discriminated against or harassed because they have migraine. The healthcare system also sometimes causes stress for people with migraine, when a lot of doctors feel a lot of skepticism. No, you're too young to have migraine. This pain is, you're not supposed to experience that much of a severe pain. Are you sure you're not making it up? These are some things that I've heard. Misdiagnosis, that people think, no, I don't think you have a migraine. I think you have some psychiatric disorder. I'm gonna refer you to a psychiatrist. Another case that I've heard. Difficulty with insurance. A lot of people feel alienated. Spouse, family, friends. People are fed up. You and your migraines again. We can't do anything with you. Enough of that. I'm tired of your migraine. A lot of people feel shame. They blame themselves for not being able to do regular activity. I hear that a lot when women, mothers come to me and say, I know I'm a bad mother because I so badly wanted to participate in my kids' event and I wasn't able to come, and I'm a bad mother. Struggle with self-esteem, a lot of negative emotions, anger with the migraine, anger with healthcare providers, anger with the people around their lives, anger with God. Why do you make me live this horrific life? We also know that when we talk about emotional stress also has been reported as a migraine trigger in majority of the people in different clinic-based population studies. We know that trauma is very much linked with migraine, because traumatic experiences have been shown to be associated with the occurrence of, first, chronic pain in general and migraine in particular. Research indicated that people living with migraine have at least 4 times higher incidence of past abuse, sexual, physical, mostly emotional, cases of neglect. And we also know that trauma also can predispose someone for other anxiety disorders such as depression, anxiety, PTSD, and so forth and so on. We also know that when someone has a higher ACEs score or higher number of adverse childhood experiences, that can correlate with an increased probability of developing migraine in adulthood. There are several prospective studies that were done on this to indicate that past trauma can make someone more prone to get a migraine later on in adulthood. So with all of that that we know about stress, about trauma, how do we deal with that? What's the solution? So first, because this connection between stress and migraine has been very well known and documented, a lot of behavioral interventions have been used for migraine, such as mindfulness, such as progressive muscle relaxation, and so forth and so on. So this is a list of most of the behavioral interventions that have been recommended for migraine. And I know that I'm talking to therapists, so it's definitely not my goal to teach anybody about all of those. I'm sure all of you know about them, but I'm just going to cover how those interventions are specifically addressed for migraine. So the golden standard for migraine is cognitive behavioral therapy because it's relatively short-term, it's very goal-oriented, and when people use cognitive behavioral therapy with migraine, they use a lot of strategies to identify and challenge all those negative self-talk and belief that people with migraine have, like I'm hopeless, no one believes me, everybody hates me, my life is ruined, my life is over, and so forth and so on. And it uses those skills to identify and correct behaviors and cognitions that might contribute to migraine and chronification and catastrophizing of the pain. Relaxation exercises, especially with people with migraine that are experiencing stress and since stress can exacerbate migraine, a range of skills, many different skills can be learned to decrease arousal and decrease stress levels, and that includes progressive muscle relaxation, diaphragmatic breathing, guided imagery, hypnosis. Even though I put hypnosis in here, personally, as someone who does hypnosis, I don't consider hypnosis just a relaxation exercise, but it is considered useful from that perspective for migraine, even though I think hypnosis can offer much more than just relaxation. Mindfulness exercise, when we teach people to focus the awareness on the present moment, letting go of what can be changed, decreasing stress, focus away from pain, all of those skills are important for mindfulness, are also recommended. I will say that out of all the studies that evaluated mindfulness for migraine, mindfulness was useful in changing the affect, the stress level, the anxiety, but mindfulness, unlike other interventions, did not have specific effect on reducing migraine frequency or severity. Biofeedback, when we use sensors to measure all sorts of physiological responses, when we teach people about muscle tension, which is more relevant to tension type headaches, heart rate variability, skin conductance, all of those skills that actually are also stress reducing and can be taught for migraine. And of course, healthy lifestyle, which is always good, sleep, making sure that someone get a good night's sleep because we know that sleep can trigger migraine, healthy eating habits, make sure we don't eat things that might trigger a migraine, hydration, nutrition, so forth and so on. However, there's a bit of a problem. And the problem is that all of those approaches, and I want to emphasize, all of those approaches are valid and helpful, and I use them as well. However, we also need to understand that all of those current psychological approaches for working with migraine, they have good, but they also very limited in their efficacy. And the big meta-analysis indicated that the effect size of those interventions is relatively small. All of those interventions are really focused on either the stress or the pain. They're really focused on the symptoms. And currently, those approaches for migraine treatment, they don't address the life adversities that contribute to chronic pain and for migraine specifically. Now, we did mention how much trauma, adverse childhood experiences can affect migraine. However, most of those interventions are not focusing on those events. Emotional experiences, emotional expression for all of those events are not being conducted usually with those interventions. So all of those interventions, again, I want to emphasize, this is not to shut down any of those, which because I use them and they are effective, but they also are limited because they focus on coping with pain. They don't address reducing pain or even eliminating pain. So I had a hypothesis, not just me, but I mean, part of other people that had the same hypothesis. I wanted to know what would happen if we can address the emotional outcomes that result from all of these adverse life events, all of those traumas that people have experienced. Will that have a beneficial effect on migraine outcomes? Will that help people with migraine, especially because there is such a need? So this is my current research that I'm doing. And in this research, I'm evaluating a novel intervention that is called EAET, or Emotional Awareness and Expression Therapy. This intervention was created by Dr. Mark Lumley and Dr. Howard Schuberner from Wayne State University and Michigan State. Both of them, I'm happy to say, are colleagues and would like to think of them as friends as well. The whole point of emotional awareness and expression therapy was that research that evaluated the link between emotional processes and chronic pain has really been growing. The fact that we have all sorts of emotional processes like anticipation that can influence and amplify pain. EAT was created and it's a manualized treatment, and it is empirically supported, and it was developed specifically for primary chronic pain conditions. There are several studies that have been done on EAT, and EAT has showed efficacy in several, both small and large scale randomized control clinical trials for different chronic pain conditions such as fibromyalgia, urogenital pain, musculoskeletal pain, and so forth and so on. And one of the things that EAT does is based on the idea that all of those adverse life experiences can cause both autonomic and central dysregulation that can trigger amplified pain. EAT works on those experiences and making changes in the perceptions of those previous experiences. And let's look at a little bit more about the core principles of EAT. There was a lot, but just kind of distilled it to several principles. Based on everything we talked in this presentation, the first principle is that the brain generates and amplifies pain, and we know that. We know that there's no other organ that creates pain. When we experience pain, like when we get stabbed in the finger, for example, that's when the danger signals start. But we will experience pain only if the brain is going to create a story that we're in danger, just like we talked at the beginning of the presentation. So we're educating the participants that pain is actually a danger or an alarm that has a bodily and a psychological danger signal. Because the brain is the one responsible for pain, we also know that difficult emotional experiences that people have in their lives, like past trauma, can cause emotional consequences that cause people to be avoidant or afraid and cause them to be stuck. And those events are also connected to the pain pathways in the brain. So we help participants have corrective experiences or corrective emotional experiences so that they can counter the ones that they are so feared of and being stuck in. The focus is on experiencing and expressive adaptive emotions, and the idea that expressing adaptive emotions is possible to do either privately, doing imagery work, doing writing work like unsent letters. It could be done in session with with a therapist. It could be also done thoughtfully in relationship, like increasing assertiveness, intimacy, and so forth and so on. And people learn to start tracking changes in their pain in relationship with their emotions. So we help our participants recognize that some emotional cues might be related to pain symptoms. And even if pain goes up because of some emotions that they're experiencing, this is a good signal because that indicates that there is something to work on that emotional aspect. EAT, even though it's novel, but it was created by other interventions that are out there, predominantly intensive short-term dynamic psychotherapy. Also, there's some cognitive behavioral exposure therapy that has been utilized, the EAT, experiential therapy, prescriptive therapy, assertiveness training, pain reprocessing therapy. So EAT contains a lot of different components of those interventions. And in general, what we try to do in the EAT intervention is first to teach the participants that they have all sorts of stressors in their life, daily hassles, relationship conflicts, private conflicts, shame, secrets, emotional trauma. All of those cause emotions. We are not living in a vacuum. But those emotions are usually very difficult to cope with. So what people do normally, because we don't want to face something that is painful, so we tend to avoid the emotions. When we tend to avoid the emotions, that could amplify pain, amplify other symptoms, and cause brain changes. However, if we're allowing ourselves first to be aware of those emotions and to experience and express them in a healthy manner, that could lead to reductions in pain and normalizing of the brain activity. What EAT does is helping people identify all of those avoided emotions and needs that people have accumulated through life, and learn healthy ways to experience and express those emotions in a supportive environment. What we do in the intervention, as I mentioned, the EAT protocol is manualized. The group session is an 8-session protocol. I adapted that for migraine in my current study. Currently, groups are very, very small just because the nature of the intervention is very intense and large groups cannot be used. So we really do maximum 5 people. That's what we found to be the most effective. We deliver that via Zoom to small groups for 8 weekly sessions. Each session is 2 hours long. In the sessions, we have lectures, discussion, but mostly in-group exercises and homework. When I say exercises, we do exercises such as the Gestalt empty chair technique, writing and sent letters, emotional expression technique, pain and emotional processing techniques, different relaxation techniques, but relaxation is not the focus on EAT. Emotional expression is. Some of the topics that we're covering is identifying the connection between life stressors and symptoms, the emotion defenses symptom triangle. So we teach them about how their defenses from experiencing adaptive and healthy emotions and needs can cause them symptoms, teaching them how to identify their own defenses, their own avoidances. So you can see that there is a very psychodynamically oriented kind of an approach to EAT. We teach them experiencing and expressing emotions like anger, like compassion, like guilt, like sadness, and so forth. We talk about relationship conflicts, forgiveness of self and others, learning healthy communications so that they can use their skills with their relationship in their life, and assertiveness training. So I what I we've done this work for quite a while now. We've got several groups. So far, this is what people are saying. I do have some quantitative data, but because I haven't published it yet, I just can't put it on a slide. I will have to say that my study currently has showed that EAT has significantly reduced migraine frequency, significantly increased quality of life. There are several mediators for this intervention, especially increasing positive emotions. And usually people that go through that, many of them find themselves really having a completely different life with significant reduction in migraine. It doesn't matter how long they have migraines before. We had one participant that 30 years of 24/7 migraines, and her migraines are significantly reduced, and she has weeks with no migraines at all. I'm not saying she's completely, migraine is completely gone, but it's not even remotely what it was beforehand. So there's a lot I want to say more about EAT, but I think that the best way to kind of show a little bit about what the process is to show some videos of what a session can look like. So I want to show two short videos. In the first video, I'm talking about shame and about secrets, because as we talked about danger signal and everything that can signal danger can amplify pain, secrets is one thing we talked about, that when we deny ourselves looking at specific parts of ourselves, that can amplify a danger signal. So in the first movie, I want to show you an example of working with shame and secrets.
Okay, everybody. So what I would like to do
Can
right
everybody hear the
now, as
sound?
we learn about shame and we learn about being shame, feeling shame about some parts in ourselves, and we learn about the fact that when we have shame, it's like we are sending ourselves the message that we're not accepted as who we are. And one of the things that we want to do when we work with shame is we know that we all carry some things that we haven't told anybody, maybe secrets, and we carry that with us. And that takes a lot of energy to keep those secrets with us. And when we're not revealing that, it's again, we're reinforcing the idea that we should not be accepted for who we are. So I want to use this opportunity, as this is a supportive group, we've been doing this for quite a while now. I would like to give opportunity to all of you to see if you can take a chance, take a risk, and share something about you that you've never told anybody. And you can take your time. And if there's something that you feel that you want to take a chance and actually express this in a supportive group, I would like to give all you the opportunity to do that. So we can do that next time, or if anybody has anything right now, then by all means.
I'm ready.
Krista.
My secret isn't anything recent, but I knew I was having marital issues, and I cheated on my husband years ago. And like the AA thing, hi, I'm Krista, and I'm a cheater.
Okay, so wonderful. First of all, thank you very much for being brave and stepping forward and doing that. I just want to say you're not a cheater. You had an affair.
Yes, I had an affair.
Okay. And so as you reveal that secret, how do you feel right now?
Embarrassed, guilty,
Mhm,
I feel fear.
mhm. So embarrassed, guilty, you feel fear. What is the fear all about? What is behind all of those emotions?
Well, I feel like people will look at me differently now that they know this about me.
So you're afraid that people would look at you differently now. And what would you like instead?
Um, well, I liked using the AA thing, so I think that when everyone shares their secret, that maybe they should do that too. That helped me feel good in a way, which is weird, but
So you'd feel better when other people would share their secret. Okay, that's one.
Yeah, and for people to still accept me.
Wonderful. So this is amazing, Krista. And first of all, I really want to say you're amazingly brave. First, by telling us your secret, and then now to be in that place of vulnerability and asking for acceptance. That is incredible. I think you're doing an amazing job.
Thank you.
So, would you ask the group and just directly at them and ask them what you would like them to do for you?
I ask that all of you would still like me for who I am and still accept me.
Wonderful. Thank you. And group, how do we respond?
Oh, I accept you no matter what.
Thank you.
Krista, I accept you and I see you, and I
Thank you.
really genuinely like you.
Thank you.
I fully accept you. Zero judgment.
Thank you so much.
Wonderful. So thank you very much for the group. And of course, I fully and wholeheartedly accept you. There is no judgment at all. I think you're amazingly brave. I commend you for your bravery to step forward. I know it was difficult to step forward and telling us your secret and being that vulnerable place and also asking the group for what you need because we all want to be accepted. You connected with your need and you asked the group. I think you've done an amazing job. How do you feel right
I feel like a weight was lifted.
now?
I I had judged myself about it for too long, so it was something that needed to happen.
Beautiful. Beautiful. So first of all, I'm really happy that this opportunity allowed you to open up, relieve yourself from the need to hold a secret. You've done an amazingly good job, and I'm really, really happy that you took the initiative. You were vulnerable. You told your secret, and you told the group what you wanted. And I'm very happy that the group was able to give you the support that you needed. Good job.
Okay. So I just want to say in here that this was one example that someone spoke up their secret, but mostly what was important is for them to identify what is it that they needed, especially because it was so difficult. So getting the secret out is one thing, which we talked about shame, but when Krista told her secret, she also felt bad because she was afraid to be judged. And so again, connecting to the need of, okay, what do you need? What would you like? And learning to verbalize it, that's a very important skill that we focus on in the as we do this treatment. However, not everybody wants to share secrets, and it is also okay. And so I want to show in the next movie what happens when someone
Okay, everybody.
what happens when someone doesn't want to share a secret, and how do we handle that?
All right. So what we're going to do right now, since this is the last session, I would like to give each and every one of you 15 to 10 to 15 minutes to do one of three things. One, either tell a secret, as we learned last time. Number two, use healthy communication with a relationship that you want to work on. Or three, be assertive. If you have a relationship that you haven't expressed your assertiveness, then you can use this opportunity to be assertive. And again, you can say as much or as little as you want, but I want to make sure in the last session we're giving you the opportunity to do one last practice. So who wants to start?
I want to go first just because I have been having migraines all week long. And I'm pretty sure it's because I have been battling back and forth on this decision for a while. But I'm gonna give myself an opportunity that I don't normally give myself, and I'm gonna say no. I'm not gonna share my secret with you guys.
Wonderful. Okay, so first of all, I think you're very brave. And I want to emphasize something. I gave an opportunity for people to share their secrets, but it's definitely not a must. And I'm not expecting people to do things just because I'm asking them. And I'm really proud of you, Victoria, for standing your ground and for saying, no, I'm not going to share my secret. How do you feel right now?
Um, I just feel really, I don't know, scared, nervous. This just isn't something that I normally do. And I'm just worried that people are going to be upset with me for it.
Fabulous. So first of all, I understand that it was difficult for you. I think you're very brave to tell us what is it that you feel right now, but it sounds as if you want something from the group. So why don't you ask the group what would you like from them?
Um,
Tell them directly. Just group, I want. Go ahead.
Group, if you could please just accept me, and accept that I don't feel ready to share my secret today. I don't know if I'll ever be ready, but I'm not ready today, and I just want you to accept me for that.
Wonderful. Group, go ahead. How do we respond, Krista?
I accept you, Victoria.
Thank you.
You're welcome.
Victoria, I accept you, and it's okay that you're not sharing your secret today.
Thank you.
I think you're really brave for listening to yourself and taking care of yourself. And I think you should be proud of yourself.
Thank you. Thank you. It means a lot.
So now, Victoria, that you've heard the entire group, how do you feel?
I mean, it's actually a huge sense of relief, because that has just been weighing on me so heavily the last week. Yeah, I didn't feel right talking about it. I don't feel like I was ready to do that yet. And I've just never really set that boundary before. I've never given myself the opportunity to set that boundary, to be able to say no when I didn't feel like it was right for me. But it feels good. I mean, it was terrifying, obviously, because like I spent the whole last week having migraines because of this, but now it feels good.
So I think you've done a fantastic job. And again, I wanna make sure I explain something. The goal of the group is not for you to all to do something that I ask you to do. I'm giving you an opportunity, and no one is forcing you to tell your secret. But I loved it that you took the opportunity to recognize what you really wanted and follow up on what you really wanted and say, no, I'm not telling my secret. So what I would like to do right now is actually help you, and I would like the entire group, I like all of us to help Victoria to assert herself and to really not tell her secret. So Victoria, what are we going to do? I'm going to start, and I'm going to really give you the opportunity to assert yourself with me and tell me, no, I'm not telling my secret. Okay. And I'm going to push you a little bit. Would that work?
Yeah, that's okay.
Okay. Okay. So just so that we can help Victoria assert herself. So Victoria, I'm really asking you right now to tell us your secret.
No, I don't want to tell my secret. Thank you.
Okay, could you be a little more assertive with me?
Dan, no, I don't want to tell you my secret, and no means no.
Wonderful. And I'm gonna push you just a little more and just like really be a little more assertive. Say, Dan, I'm not doing what you asked me to do, or whatever version you feel like. Go ahead.
Dan, I am not going to do what you're asking me to do because I don't want to.
Back off. Tell me.
Back off, Dan.
Beautiful. Fabulous. Excellent work.
Okay.
Okay, let's.
Well, I'm gonna stop this video, but what I did want to say about this scene, Victoria was pretty much a people pleaser. She never stood her ground. She always did what others asked her to do. And as I was leading the group, she came to the session anticipating that she would be forced to tell her secret, and she had a migraine the entire week because of that conflict. One, she didn't want to do it, but she was such a people pleaser, she was afraid to say no. And so by giving her the opportunity to assert herself and find out what she really wanted and test her boundaries and actually teaching her to be more assertive, afterwards, her migraine was reduced. So this is just tiny example of some of the work that we're doing with EAT. And so that with that, I just want to summarize the presentation. And we started talking about pain, that pain is evolutionary conserved phenomena. It has both a physical and an emotional component, and it warns us of real or potential danger. We know that pain occurs if the brain thinks that we're in danger, and it will create a pain response to warn us of something. In chronic pain is if the brain was stuck in some sort of a danger mode. And so what we do usually in EAT is that we understand that the brain is in danger mode and we try to identify what's the danger signal and reduce them. We talked about migraine, which is a chronic episodic disorder that affects significant proportion of the population. Anxiety and mood disorder are very much comorbid with migraine, and they warrant the use of mental health approaches. Current mental health approaches like CBT, mindfulness, relaxation, hypnosis, biofeedback, they're all wonderful, but research indicates that they're very limited. And current recommended behavioral treatment, they actually don't address the underlying trauma that has been shown to contribute to the occurrence of migraine. So this novel intervention, emotional awareness and expression therapy that does deal with the emotional ramification of past experiences, currently is showing promise. We keep doing the study, and hopefully we'll be able to get more information about that soon. If any of you are interested in learning a little bit more, any questions about migraine, any questions about EAT, then please contact me. I put my information here, my phone number and my email. On a different note, if anybody is working with people that live with migraine or know people that live with migraine, we offer free resources. Several courses, all of them are free. EAT is also offered there. I'm offering that treatment as part of the foundation as well. This is the website. You can go online, and people that are interested and people with migraine can just enroll. Unfortunately, there is a basic course, and only when you finish the basic course, then you can get the advanced courses. We just started the basic course 2 weeks ago, and so the next course is only going to be the beginning of 2025, but there's other courses that we try to give constantly. And at this point, if I hopefully haven't given anybody a migraine or a trauma, that pretty much concludes my presentation, and I thank you very much for your attention. Thank you.
Thank you so much. That was really interesting and informative. Does anyone have any questions for Dan? I guess I have a question. So did you say that there were groups open and available right now for people experiencing?
Well, so we just finalized recruitment for my study. So there are currently no, I mean, we don't have participants, we don't recruit participants to the study. However, EAT is offered as part of the foundation, but we just finished a group, I think about a month and a half ago. The next one is going to be in 2025. So, I mean, people can enroll. It's just that it first comes, first serves basis. We're trying to make it available for everybody, but we are a bit limited, but we still offer many resources currently in different, different modalities through the foundation if people are interested.
Okay, awesome. And also just to clarify, I can't remember the name of the type of therapy. I can't remember the acronym.
EAET, Emotional Awareness and Expression Therapy. Yeah.
Okay, and that's something that you and your team have developed, and that's what you're researching.
No, so this was developed by Dr. Mark Lumley and Howard Schubiner from Michigan. They've evaluated that in other chronic pain condition. When I learned about it, I thought it would be a very good idea to test it for migraine. And currently, my research indicates that it is showing potential. So we want to keep doing that research. So.
Okay, gotcha. Okay, and if we were interested, if anyone was interested in learning that modality, there a particular way to do that?
Yes. So there are, so EAT currently is so Dr. Lumley and Howard, they're offering EAT training for therapists. You can actually go online and look. The upcoming course is in November. I'm also going to be teaching in that course. And we're also working with my colleague, Dr. Brandon Yarns. We are developing a group EAT training because the EAT course that is offered right now is pretty much to teach EAT for therapists. It's not focused on necessarily how to do that with groups. So we're developing specifically group EAT to really teach therapists that are interested specifically in the group format in how to do it, because there's a lot of specifics when you go to do EAT with group versus a one-on-one in therapy. So these are available. The group EAT is going to be available beginning of 2025. The regular EAT course, which is an amazing course, it's starting in November, and you can go online. Sorry, I didn't put the link to it, but you can find it online. And if not, you can contact me and I'll send you the link. That's no problem.
Okay. Very cool. Thank you. Does anyone else have any questions?
Yeah, I just further clarification on the group that
Sure.
starts in 2025. Can you talk a little bit about what the cost is, if it's covered by insurance typically, or what that looks like for folks?
Yeah. So there's several groups. The study group, unfortunately, that is not open, but the groups that are open through the foundation, there's no cost. It's free. So the foundation offers all of those treatments for free for people with migraine. So that includes the basic course, which is called Resources for Migraine Management. That's going to be in January 2025. That's a 6-session on Saturdays, because that's the convenient for a lot of people. And that offers all sorts of skills. Relaxation, pain modification, cognitive behavioral intervention, all sorts of skills. And once people complete that course, they can apply for any of our advanced courses. So there's an advanced course in biofeedback that people are actually getting sensors for biofeedback, and they're getting everything for free. The foundation is really generous. They created the foundation because they want to make sure that they remember their daughter. Their daughter had migraine. She committed suicide. And the Henry family, who created the foundation, decided that they want to make sure to help other people with migraines so that they won't experience what she experienced. So they provide all of those courses for free. So we have biofeedback, we have the basic course, we have autogenics and EAT, and we have forgiveness for migraine course. So all of that is offered for free.
That's really great. Thanks for that. And thanks for the presentation. It was very informative.
Thank you. Thank you.
Thank you so much, Dan. And good to see you. And
Likewise.
I'm curious if you spoke quite a bit about chronic pain in general.
Yes.
Would you say EAET is also really a fabulous intervention for people who experience chronic pain?
Okay, so EAT was created for general chronic pain condition, not for migraine in particular. The first studies that were done were on fibromyalgia, urogenital pain, musculoskeletal pain, and there's other studies that were done to evaluate EAT's effectiveness with other forms of chronic pain. So the answer is yes. It's at this point, because it's relatively novel intervention, I can't say, okay, it's effective for everything. We don't know. We're assuming it is, but of course, more research is recommended. But currently now, it looks like EAT has the potential to be effective with other various forms of chronic pain. We're looking and seeing that it also helped with migraine. So again, another pain condition to the list. Yeah.
I have more people that just are in my client list that experience fibromyalgia. They're just showing up. So that's great to know. And then those resources, though, the free ones are only if you qualify with the migraines. That's okay.
Unfortunately, yeah, because the foundation is specifically focused on people with migraine, but
Totally.
there are people that work with other form of chronic pain conditions, and they can help other people. So yes,
cool.
Those resources are available.
Thank you so much.
Thank you.
Well done.
Hi. Oh, sorry. I'm so sorry I got held up. So I just managed to see the last part. Is this being recorded, and is there a way I can access this again?
Yes, so this is being recorded. And is it Lucille? Is that how you say your name?
Pardon? Lucille.
Lucille, okay. If you email me, I can make sure to get you the recording. But if you purchased the ticket for this presentation on Eventbrite, then I already have your email.
Yeah, I purchased the ticket, so yeah.
I'll send out the recording and see
Thank you.
Next week.
Okay, thank you so much. I'm so sorry. It looked really interesting. I'm sorry I missed most of it.
That's why we record. All right, any final thoughts, questions? Yeah, this was very interesting. Thank you so much, Dan.
Of course, you're welcome, and good luck to everybody. If there's anything I can ever help anybody and of people with migraines, and please feel free to contact me at any time. Thank you.
Okay.
One last question, Dan. I don't know if
Sure.
sometimes presenters are okay with sharing their slides. I'm not sure how you feel about that.
So some of the information I'll need to think about it, because some of the information is still not published, but I think it should be okay.
Okay. And I can send that out to people too.
Sure.
If it's okay with you. So
Sure.
and then yeah, if anyone wants to get in touch with you,
Sure.
I'll just send them your email as well.
Yeah, so my last slide had my contact information, or I can I don't know if you want me to put it in the chat or whatever works. I can just I can write in the chat my phone number if people are interested, and my email. So I just put my phone number, and my email is also in the chat. So
Okay.
and of course, if you have the presentation, then the last slide, all my contact information is there as well. And the foundation that provides the resources is the Danielle Byron Henry Migraine Foundation. You can Google that. It's pretty easy. I'm going to put it in the chat as well. Danielle Byron Henry Migraine Foundation. So if anybody's interested, you can just log in and just register, and it's pretty easy.
Cool. Awesome. And I'll try to remember to send out your email in
Sure.
the.
Sound good? Okay.
All right. Well, thank you all so much for joining us. I hope everyone has a wonderful evening.
Okay. Thank you all.
Thank
Bye-bye.
you.
Bye.